All right, talking quickly about headaches in general, focusing on migraines specifically. There are a lot of different types of headaches, and again, we're going to focus on migraines for this lecture, but there's tension headaches, trigeminal autonomic headaches, which also could be described as cluster headaches in some cases, or there's a number of other kind of odd types of headaches that fit into that category. This trigeminal nerve also is thought to be involved with migraines as well, so migraines might technically kind of fit in there too. Chronic daily headaches, so somebody who just gets any type of headache more than 15 times per month. That's just a diagnosis type thing. And there's plenty of other causes. Certain medications, when used frequently, can cause headaches, or when taken away, can cause headaches. Things that affect the brain, obviously tumors, cerebral vasculature issues, sinus pressure, or trauma can all cause headaches. And migraine, the definition of it's an episodic disorder. It's a severe headache associated with, usually, doesn't have to be, but it's usually associated with nausea, and you can have light or sound sensitivity as well. The most common neurologic patient complaint out there is a migraine. So again, if you work in neurology, you're going to see migraines as a really common kind of outpatient, regular patient type complaint. Affects up to 12% of the population. It's more common in women than men. 17% of women have migraines, 6% of men. The traditional theory basically was just that, well, it has something to do with how the cerebral vasculature is dilating and constricting. There's some imbalance there. We don't really know exactly what, but that's why. But there's thought to be a lot more complicated than that, because if that was the case, we should be easily able to treat migraines more so than we can, because migraines can be pretty difficult to treat depending on the patient. So there's a number of other theories out there that involve more complicated nerve systems. So again, the trigeminal vascular system becoming more sensitive to pain-related stimulation, different types of serotonin receptors in the brain, and some other things out there as well. Those are kind of the main items at play right now. For patients that get migraine, I think we can think of things as having phases, but not all patients will get a phase. So for example, prodrome, you might hear of somebody who gets a prodrome when they have a migraine, so they have some sort of thing that happens before they get the migraine that they know. It's like, oh, I start to yawn, or I have this weird difficulty concentration. I can feel a migraine coming on. That only happens in a little over half of patients. For people with aura, that might be some sort of situation that lasts shortly right before the migraine happens, and that's even less common. Then, of course, the headache. Everyone who gets migraines gets headaches, right? So that's going to be the main feature there. And the postdromal phase, sensitivity to light, lethargy, things like that. It's very similar to actually seizures. So when you talk about epilepsy, there's a similar kind of pathway that happens here. Basic treatment for migraines is really what we've talked about for pain control. There's not a lot of difference for the standard migraine patient. We really do want to try the basic medications. As far as evidence go, aspirin and NSAIDs, specifically ibuprofen, naproxen, and diclofenac, have all been studied to be effective for patients with mild migraine symptoms. So we should always be trying, we should probably be using NSAIDs, at least from a synergistic perspective, with other things we're using as well. So those are probably going to be the go-to for the majority of patients. Acetaminophen is an option too. As we've talked about already, acetaminophen has mixed evidence for how effective it is as a pain reliever, but it's worth a shot to see if it helps or not. What I would say is, like I always say, is make sure you're maximizing your dose. So don't give like a 325 milligram dose of acetaminophen. If you're going to give acetaminophen for migraine, you might as well give a dose that's going to actually work, if at all. So that would be 1,000 milligrams. So just go right to the max for any patient. For ibuprofen, I'd also kind of err on this higher dose. Usually you're seeing ibuprofen cap out at 800 milligrams for a normal dose, but actually there's some studies that show people using up to 1,200. Now, I will give the caveat that people in the United States, at least, do not use 1,200 milligrams of ibuprofen. I've actually never seen that ordered, but I did put it in there because technically it has been studied giving higher doses of ibuprofen for single episodes of headache. And same thing with naproxen. These are really high doses. Normally you only see like 500 milligrams used as the high dose, but you can actually go quite a bit higher than that. But again, I wouldn't necessarily recommend saying this to a provider because they might look at you a little weird. Just wanted to give you a feeling for how people are using these maybe outside of the United States, where they might use NSAIDs a little bit more aggressively than we do. But certainly, there are normal doses and there's quite a bit higher ones, and we can push that envelope a little bit. What people tend to do in the United States instead is instead of pushing a really high oral NSAID dose, they just give a higher dose of something like ketorolac instead, which is much more common. We've talked about NSAIDs already. I'm not going to rehash the mechanisms here. There are some combination options that I would say are, have varying degrees of success. There's certainly going to be people who like to use these, whether or not they actually work or are effective, or I would recommend them. I don't think I would. I kind of stay away from caffeine-related regimens, and while they can work for headaches, people who overuse caffeine can get really bad rebound headaches too. So that can be a double-edged sword. But Excedrin is probably one of the more common over-the-counter products. It's marketed for migraines and headaches, and it's a combination of acetaminophen, aspirin, and caffeine. You can get it over the counter. It's got 65 milligrams of caffeine per tablet, a little less than a cup of coffee there. So caffeine basically works centrally active. It does a number of things, but it vasoconstricts centrally. But again, once that wears off, you can get a rebounding vasodilation and cause a withdrawal-type headache. There's another product called Fioricet, which is acetaminophen with caffeine, and a drug called butalbital, which is like a weak barbiturate. We haven't talked about barbiturates yet, but they're basically sedative drugs. There's also a formulation of Fioricet that has codeine in it too, so it's actually got a weak opioid, so you're kind of getting a weird cocktail of medication. The opioids in place of the butalbital, so it's acetaminophen, caffeine, and codeine versus butalbital. But Fioricet by itself is a non-controlled substance, whereas with the codeine it becomes a controlled substance. Again, I don't necessarily recommend using these. Usually it's like a patient comes in from outside, at least from what I see in the hospital. Somebody comes in and they take this at home and it works for the headache at home, so their inpatient provider orders it for them. I rarely see people get started on these because, I think it's a slippery slope. If you use them a lot, you end up getting a pretty severe rebound headache because of the caffeine component. This is a little bit funny. These are both packaging of Excedrin, and so this is Excedrin. I can't remember which one is which color is which. Doesn't matter. One's Excedrin regular, and one is the Excedrin Migraine recommended, and specifically branded that way. And you can see they're actually exactly the same thing. I remember this when I was in high school. I worked as a pharmacy technician in a retail pharmacy, and I remember some lady came in just mad because she said, I bought Excedrin Migraine, and I realized that when I got home that it was exactly the same thing as Excedrin. How can they market it that way? And the pharmacist just kind of threw up her hands and was like, well, it's just the way it is. They can put whatever they want on the bottle. They don't necessarily have to change the dose just because they're doing that. And that's sort of one of those interesting examples about OTC labeling and how it's always good to be able to check the back of the box and see what exactly is in the product, because these again are marketed slightly differently, but they are exactly the same thing. So you see this one says specifically for using to treat migraines, whereas this one is marketed more as a general pain reliever. You'll see headache is listed on there generally. So it's a little sneaky, I think. I'll just make one product, but that's the way they've done it. All right, let's talk about triptans. Triptans are the major class of medications that are used to treat migraines that are prescription only. They're serotonin 1B, 1D agonists, meaning they agonize specific serotonin receptors in the central nervous system. They're specifically used for migraines. Don't have any other roles in medicine. Their mechanism is to inhibit the release of vasoactive peptides. They promote some vasoconstriction. And then there's a number of other things that are suspected that these medications do, like blocking some roundabout pain pathways that are unique to migraine-type headaches. Anyway, this is all they're used for. They aren't used for any other types of pain syndromes. There's 7 different triptans available. Lots of formulations out there, and they're all found to be equally effective. No one triptan is better than another per the current body of evidence we have. These are all the triptans on the market. You can see the most important things to know, I think, just from a general practitioner perspective, and when you're treating your patients, if you're trying to decide what triptan to prescribe, is how they come. So the vast majority, they all come as an oral tablet, so that's the basic presentation. And then you'll notice there's some that come differently. So, for example, rizatriptan and zolmitriptan come as an orally dissolving tablet. So for somebody who gets severely nauseous during their migraines and they can't swallow something, they might be able to let something dissolve in their mouth. It might be easier for them to take it that way. The orally dissolving tablets, if you notice, actually, like for example this one, doesn't really have that faster of a Tmax here. And if we look at zolmitriptan, it actually has a longer Tmax. So why that is, I'm not exactly sure. Bioavailability is about exactly the same. And I think the thing to remember about ODTs as well, I think sometimes people think, well, it's dissolving in my mouth, so it's absorbing sublingually or buccally. It's not. You still have to swallow ODT products to get them in. So I don't know what the deal is with the ODT, but it does seem to actually have a bit of a longer duration to get to that max concentration, which is interesting. So whether or not you actually want to use the ODT, you might want to question that. So I just want to point that out to you because the absorption is quite a bit more variable than the regular oral tablet. When you get a little more creative, there's 2 nasal sprays on the market, zolmitriptan and Sumatriptan. You can see those are here. You notice that disjointed transition. I got interrupted there for a second. Anyway, Sumatriptan and zolmitriptan have a nasal spray, which you can see isn't necessarily a faster onset than its oral tablet. In fact, the Sumatriptan is quite a bit faster, but the zolmitriptan, for whatever reason, isn't. So not necessarily a reliable way to get it into the system faster. Really, the fastest onset by a long shot is going to be the sub-Q injection of Sumatriptan. It's the only one that's injectable. So for an emergent headache, urgent care, emergency medicine type thing, this is going to be the one you're going to use primarily if you want something faster than an oral medication. Let me go back quick. I did want to point out just the variable different kinetics out there. Some of them last longer than others. So you'll notice like Provatriptan has a really long half-life. It's a slower acting one, but for people who get rebound headaches after their triptan wears off, like compared to Sumatriptan, 2-hour half-life, rizatriptan, 2-hour, a lot of them are actually quite short. This one can have a more sustained effect, which can be beneficial for those patients. It really lasts significantly longer than any other one out there, but it is a slower acting medication. So for people who maybe get a prolonged prodromal state or aura or something like that and know their headache's coming on, it might be good for them, but it might be kind of too late for some other people to get that into their system in time. So Sumatriptan is Imitrex is the brand name of that, and it's the most common one that's used. And again, it comes sub-Q, nasal, NPO, and the sub-Q Imitrex is the fastest onset of action. Side effects are flushing, weakness, dizziness, drowsiness, chest pressure. Those are across the board with every triptan. Sumatriptan has been around for quite a while, so it's generic, but there's a brand name version of it that's combined with naproxen called Trexamet. Save your patients some money and just prescribe them separately. There aren't very many head-to-head trials against triptan comparing them, and basically they've all been shown to have the same effect. Rizatriptan, or Maxalt, was the one shown to have the fastest PO onset. So if you're looking for an oral medication that's faster onset than Sumatriptan, if they aren't doing well on that, if your patient needs something faster, that's probably the way to go. And while Naratriptan and Provatriptan might have a slower onset and lower efficacy, the long half-life might be beneficial for patients. So really the moral of the story here is when it comes to selecting a triptan, you're going to focus on pharmacokinetics, and if the patient doesn't respond to one, try a different one. And there's not really any more of a roadmap I can give you than that, other than using your pharmacodynamic knowledge and understanding how the drugs work and tailoring that to your patient as best you can. Again, triptans are pretty well tolerated. There's common side effects. We just said that. A couple of warnings. You aren't supposed to exceed a certain recommendation of dose per day. So for example, with Sumatriptan, it's 200 milligrams in a day. And the max dose you can take at one time is 100 milligrams. So if somebody comes in and they're at home and they took 50 milligrams of Sumatriptan and then they took another 50 milligrams 2 hours later, they come into your emergency department, they could get another 100 milligrams, or the sub-Q dose that comes as a 6 milligram is equivalent to basically a full oral dose. So you have to make sure you're talking to your patient. Obviously, you do that, but it's really important to make sure that you're clear on what they've been taking, when they last took their dose, because that can be problematic potentially. The risk here has to do with a couple of different things, but usually it's about cerebral or coronary vasospasm with excessive doses of these medications. It's rare, but it can happen, so we want to restrict. And we're actually pretty hardcore about that. We don't go over it. We don't make exceptions. If that's the max dose they've taken, we move on to the next one. And ultimately, if you've given that much triptan, the odds of giving more probably isn't going to be all that effective anyway, so might as well try a different drug at that point. There's another medication called class called ergot alkaloids. There's really just one medication here. It's called dihydroergotamine, or DHE. It's an IV-IM sub-Q intranasal med. There's no PO dosage form. It's a little bit more potent than a triptan, but it works similarly. It also has CYP3A4 substrate, so as far as drug interactions go, it could be substantial. It's really useful if you want to try something that's not a triptan. The one thing to remember is this little caveat here: do not use within 24 hours of dihydroergotamine. That goes both ways. So if they've already taken a triptan, don't use DHE, and if they've used DHE, don't give them a triptan. Antiemetics are useful for headache, migraine by itself. They also have, obviously, help if somebody is nauseous. And so these ones have all been studied. Most of the time you're seeing the top two being your common ones. Yeah, I don't really have much else to say about them. Usually the dopamine antagonists are going to work better than like just ondansetron, but certainly you could give some ondansetron if you wanted something additionally for nausea. A couple other options. IV-IM ketorolac is going to be a really common option for migraine patients, especially ones with nausea. And IV caffeine use is occasional. There are a couple IV caffeine formulations on the market, although it's more rare. Where I see it used more frequently is for people who have headaches associated with procedural type things, but it's still not super common. Valproic acid infusions. Valproic acid is an anti-epileptic drug we haven't talked about yet. We'll talk about it more in a coming module here shortly. But basically, the IV form of it can be given in high doses and can be useful for migraines. And then high-dose steroids, so either IV dexamethasone or IV methylprednisolone, are commonly used as an infusion to stop a migraine. So those are kind of the more advanced steps that you get. So if you hear of people who, when they have migraines, they have like a treatment plan and they go into an infusion center or an emergency department to get their medications, this is probably what they're getting. A lot of times I'll see somebody come from a neurology clinic and they'll have a pretty straightforward plan. It's like, okay, when the person comes in, you give them ketorolac, you give them prochlorperazine, you give them valproic acid, and then steroids. Really the idea here is let's throw the kitchen sink at this person. Hopefully we stop the migraine from happening. And then ultimately we're going to avoid using opioids if we can. Now that person probably has triptans that they take at home. They probably maxed out on their dose at home, and now they're in the ER with a treatment plan, getting all these other medications. There is a new drug called the CGRP class, which is calcitonin gene-related peptide antagonists. And as far as acute migraine use, there's a couple oral medications on the market that just got approved. One got approved, I think, last winter, and one just got approved in February. They're brand new. They're essentially, from what I can read about them, they're used kind of like a triptan, where you give it before a migraine or kind of at the very beginning of a migraine start. But they were just compared to placebo in their clinical trials, which they were effective for, but they weren't studied head-to-head against triptans. And so being new and expensive, it's probably going to be a while till we see these used, and it's going to be probably necessary to get some better evidence on whether or not they're an improvement over the current triptans, or they offer better safety data or something like that before you try it. Now, for people who have had no success on any oral medications as an outpatient so far, this might be a great choice for them, but that's really going to be the only patients they're going to be applicable for in the near future. Again, we need more evidence to make more sweeping recommendations. So a summary, for mild to moderate with no nausea or vomiting, simple analgesics like acetaminophen, NSAIDs, and aspirin. Moving on to a more moderate to severe pain syndrome, looking at either a triptan by itself or the combination sumatriptan plus naproxen. I'd suggest if you're going to give an NSAID, naproxen is probably the better choice just because it's longer acting, but that's up to you and up to the patient, of course. For severe would be more like an emergency room presentation with nausea and vomiting present, and that's where you'd probably look at sub-Q sumatriptan, IV antiemetics, ketorolac, and then further from that, you could look at DHE as an option, IV dexamethasone, IV steroids, and valproic acid. I didn't put opioids on here. Opioids would block the pain of a migraine headache probably in most patients, but they're not going to do anything to stop the headache. So once they wear off, it's going to be right back where it started. So and certainly there's of course addiction and more side effects and all that type of stuff associated with opioids. So generally want to avoid them for a migraine. I'll mention cluster headaches really quickly. They're super rare, like less than 1% of the population, and actually these affect much more commonly men than women. There's some thought that these are associated with sports or head trauma, but not proven. Don't really know what causes them. Basically, it's a severe orbital, supraorbital, temporal pain that occurs up to 8 times a day. It's these very short-acting, intense, painful headaches, and they usually occur over weeks, and then they'll stop. Remission can be for more than a year or so, and then the patient will go back into it again. From what I understand about pain syndromes, this is supposed to be one of the most painful things a human being can experience. In fact, cluster headache patients are at very high suicide risk during a cluster episode because of the significance of the pain. Treatment is similar to a migraine, but a lot of things just don't really work very well for cluster headache patients, which is really challenging. Some things they'll try is just getting somebody in a really dark room and giving them high flow oxygen can help. The other thing that they might try is intranasal lidocaine, which kind of is it's a local anesthetic, which we're going to talk about in the next lecture quickly. But it'll help with, supposedly it helps kind of with some of the numbing of the sinus area and stuff like that. It might decrease nerve transmission around these areas, the orbital, supraorbital, and temporal areas by intranasally administering the lidocaine. So those are the options. Preventative medications is key. So to prevent these from happening to begin with is great, but it can be really difficult. We've had a couple patients who come into the ER with these, and every once in a while, they start up, and it's hard to see because a lot of these people end up on pretty heavy opioid regimens because there's nothing else that's working very well for them, and it's pretty disruptive for your life. You can imagine for weeks coming in and out of the hospital, getting heavy doses of hydromorphone because nothing else is helping your pain. Medication overuse headaches most commonly are from caffeine or opioids. NSAIDs and triptans don't have a huge association with this, which is another reason why we like to use them for headaches versus these types of products. But really, stopping the medication and getting them onto a different one for their migraine is going to be the ideal treatment here. Prevention is really important for migraines, just to keep people healthy, to keep people functional in their daily life. Lifestyle things have been shown to be very effective, so sleep hygiene, scheduling meals, exercise, and managing specific migraine triggers have all been shown to be beneficial. From a medication perspective, controlling blood pressure is a big thing, but specifically even if people don't have blood pressure issues, propranolol and metoprolol, beta blockers, have both been studied and shown to be effective. Propranolol is probably the more common one I see used. It's less selective, so it probably has a more broad sweeping effect on suppressing the sympathetic nervous system, which seems to help with migraines. And verapamil is probably less effective than the beta blockers, but it's been studied and used for quite a while for migraine prevention. It's a pretty well-established therapy. There's a couple antidepressants, specifically one called amitriptyline, which is a tricyclic antidepressant, and a drug called venlafaxine. Both these drugs block the reuptake of serotonin and norepinephrine in the central nervous system, so they can have some effects that are positive for migraine patients. And if you have a patient with comorbid mental health disease as well, it can be a nice drug that does two things at once. Anti-epileptic drugs, or AEDs, valproate and topiramate, are both used for this, and we'll talk about those in a couple lectures here. And then the newest class are these CGRPs. So you might say, didn't we just talk about those? And we did, but kind of the interesting thing is there's two different types of CGRP drugs on the market. There's the ones I just talked about that would be used for an acute migraine, which are oral medications, and there's injectable MABs, or remember that's monoclonal antibodies. So these are biologic agents. There's 3 of them on the market right now. As you might imagine with any biologic agent, they're very expensive. They have been shown to be pretty promising. So for people who, again, have tried lots of different things and haven't gotten anywhere with migraine prevention, it could be an option for them. But for the average patient, it's really expensive. Insurance probably won't pay for it. And there really isn't long-term data to support that they're safe and effective over, years and years of therapy. So again, these are just really too new at this stage, but it's worth talking about them just to get the conversation going. If you've watched any TV over the past week or month or year, you've probably seen ads for these. I know I've seen several. Botox is used for people who get frequent tension-related headaches, and they can actually inject around the base where the neck meets the skull here, and kind of around the neck muscles, and then in the temporal and forehead areas too, to make it so that the nerve impulses don't go as frequently, and hopefully the tension gets relaxed there. So that's something that's done as well. Obviously a little more expensive, a little more invasive, and more complicated, and Botox has to be given every 3 to 6 months or it stops working. So it's sort of a thing that you'd have to do regularly. And Botox also has sometimes just will stop working for patients. Your body eventually develops, I shouldn't say for everyone, but sometimes for some people it eventually develops antibodies to it, and it just no longer works like it used to. All right, that's it for migraines.